afternoon. Thank you for the invitation. Thank you to Dr. Habib and Dr. Khaled for having gathered all this panel of exceptional international speakers. As mentioned before by Professor Sanda, beauty is subjective, and blepharoplasty is among the most performed cosmetic surgery over all cosmetic surgeries. Complications are very uncommon, and most of the time these complications are simple to manage, especially in hands of experienced oculoplastic surgeons. The objective of my topic today is to identify the risk, in order to avoid the complications, and how to manage these complications. We have to answer to 3 questions: when to do the surgery, whom we have to give the surgery, and how to do the surgery. I will not go through all the complications because we have a lot of complications. I will emphasize on the most frequent that we may meet if you have an expertise hands for these surgeries. Here are the most common that we meet every day in our practice, even for a confirmed cosmetic oculoplastic surgeon: mild edema, chemosis, a preseptal hematoma that you can drain and just offer a preservative treatment to the patient, a conservative treatment to the patient with ointment and cold compresses, and usually it passes after 3, 4, or 6 weeks, and to reassure the patient. How can we avoid these complications? My previous colleague has developed the importance of careful preoperative assessment, detailed clinical history of the patient. Is there any comorbidity, any risk of bleeding, any past bleeding surgery, and a careful exam of the patient, laxity, excess of skin to remove, etc. I will especially emphasize on the psychological status of the patient and the patient expectation. As mentioned previously, patients sometimes will come to your office with a picture of a star, of someone that he wants to look, and not always the picture that was of him at 20 or 30 years back. At this level, we have to ask to the patient to voice what is his desire, what he wants after the surgery, what he's looking for, what is the objective of his visit to your office. And sometimes this objective is not conversion to the objective that the surgeon, the oculoplastic surgeon, can give to the patient. In this example, both are smiling before the surgery because the lady is expecting this result, because that's the way she sees herself, and the surgeon knows what will be the result in his hands. Then if these are not convergent, the opinion and the objectives from the beginning, you will be in trouble with your patient. Then you have to customize the surgery. These 2 patients coming for blepharoplasty, we all agree that they need blepharoplasty, but each one, you will have a different protocol, a different way of doing the surgery, as previously detailed by eminent speakers. The next question is when to do the surgery. You have more and more young patients, I can say even very young patients, coming to our office asking for a surgery. We have, as a surgeon, to learn, to know, to say no. It's not the time. You have to wait for the surgery and not to jump for the surgery. And usually we see these patients after 3 or 4 surgeries done before, from the age of 20 or even less sometime. And then to define the objective. What's the beauty? What do you want after the surgery? Is it realistic? Is it possible to do this surgery? Yes or no? And then, now you decided with the patient, you go for the surgery, and what type of surgery? What do I have to do? Now you are alone with you, your assistant, and your decision is in your hands, what to do for this patient not to get the complications. I will not keep longer because here it is already mentioned. Each patient has his own surgery, tailored, customized surgery. If I remember when I started doing ectropion surgery, the same surgery for all the patients during my residency program. If you keep on doing the same surgery for all the patients, for sure one day will have a problem and complication. Then each patient needs a customized, a specific surgery. All the techniques, contoplasty, you have to master not to be in difficulty. Now the management of the complication, I took sample of this complication. I will not speak about the diplopia. I'm elsewhere doing some strabismology. Then you can damage the muscle, or sometimes the patient get diplopia because only of the local anesthesia or edema of the muscle. But I choose these complications that are always challenging for the surgeon, because you have to explain to your patient that it happened and I know how to manage it. To be honest, most of the time this patient is coming to you because had surgery somewhere else, and you have to manage the complication. It will not stay back with you if you get this complication. The eyelid retraction is most of the time due of extensive skin resection or fibrose of the intermediate lamella. It is, yesterday we shown that it is the septum and the tractus muscles. Usually the treatment is based on posterior lamella graft or lengthening, and you can use epidermis, hard palate, pericardium. I used to advise to use what you are used to do, what you are comfortable with. Don't look at the technique that you saw in the last paper and I'm going to try this one. The best technique is the one that you master the best. And when it's the anterior lamella that it is shortened, is usually based on skin graft, skin flaps, or skin expansion in some situation. The other complication is the ectropion. Here it's probably because of lack of preoperative assessment. The laxity of the patient was not treated. And it's quite easy to treat the patient. You need to do a lateral contopexy, contoplasty, different techniques and different way of treating, but the objective is the same as the tarsal strip of the inferior lid. The lateral canthus deformity is also a common complication, and sometimes there is a different opinion between the patient and the surgeon. The patient considers that the result is insufficient, but the surgeon considers everything is okay. Then usually when you see the patient, his complaint is because of this aspect of round eye. Same, when you accept and recognize and see the problem, the treatment is simple. I can say simple in expertise hands, is based on lateral contopexy with or without contotomy, depend on your habit. Some extremely rare complication can threaten the vision, and it happened very rarely. This is due only to the surgeon and the complication in the hospital. It's nosocomial infection. Orbital cellulitis has to be managed as any orbital cellulitis with admission of the patient, IV antibiotics, and drainage if needed. Here is the complication. I found this last paper published on 2019. It's extremely rare, 0.005%, as mentioned before by Professor Richard. But the patient who remain blind are even less. This is the number of the complication of retroorbital hematoma, but the blindness is even more rare. My opinion as oculoplastic surgeon, doing, I can say weekly, this oculoplastic surgery and cosmetic surgery, is the insatisfaction of the patient. Here your patient, for you everything went smoothly, the surgery is okay, the result is fine, but still the patient is unhappy. Then you have to find a solution for this patient. I consider that in this situation, if you feel that the surgery was fine, everything is fine, you have to look for something else. You have to widen your view of the patient. This patient, for example, had blepharoplasty but still unhappy. Maybe we can offer something else. Of course, she considered herself not in the result that she was expecting. For this patient, I went and I offered lipostructure, that's maybe a French word, but fat filler with her autologous fat. And this is quite easy to do, quite easy to learn for an oculoplastic surgeon. And you know with the time how many of volume that you have to inject, and you may get the happiness of your patient and the thanks of your patient. Thank you for your attention.